gestational trophoblastic disease from Berek and NOVACS 16th editions. The gestational trophoblastic disease is the term used to describe the heterogeneous group of interrelated lesions that arise from abnormal proliferation of placental trophoblast. It can be a benign disease, it can be a malignant disease based on the histology. If there will be benign lesion, it can be a hydrated moles, it can be partial or complete, or whereas the malignant lesion consists of invasive moles and placental site trophoblastic tumor, epithelial trophoblastic tumor, choriocarcinoma. Okay. This subset of malignant lesion that have bearing propensity that will lead to local invasion, and it can lead to metastasis, that is called as gestational trophoblastic neoplasia. Although GTN commonly follow molar pregnancy, okay, but that there can occur after any gestational event, any it can be abortion, it can be ectopic, it can be a term gestation, any gestational event that can lead to gestational trophoblastic neoplasia include induced or spontaneous abortion, ectopic pregnancy, term pregnancy, everything's included. Okay, remember this thing. Then hydrodiform moles, the incidence 2 in 1000. Based on thorough pathology, how to differentiate between the feature of the hydrated mole? You differentiate. First is feature of complete mole. There are this the 6 points, that is fetal or embryonic tissue. Okay, if it is absent, then it will be a complete mole. Hydrated form swelling or chorionic villi, it is diffuse, it is complete, focal in partial. Fetal embryonic tissue is present in partial mole. Trophoblastic hyperplasia is diffuse hyperplasia, it is complete and partial focal hyperplasia. Scalloping of chorionic villi is absent in complete and present in partial mole. Trophoblastic stromal inclusion, it is absent in complete mole, it is present in partial mole. Karyotype, usually the complete mole, that will be a empty ovum. Empty ovum means it will be diploid, always it will be diploid, but it can be 46XX, that is 90%, it can be 46XY, and in partial mode it always triploid. Okay. Usually this molar pregnancy that will can be attributed to the low socioeconomic nutritional factors. The case control study, the rate of complete mole increase with the decreased consumption of the dietary carotene, vitamin A precursor and animal fat. Maternal age and the reproductive history influence the rate of molar pregnancy. When the older than 40 years have to 10-fold increased risk for complete mole, which 1 in 3 pregnancy in women older than 50 years. Okay. The adolescents have a 7-fold increased risk of developing complete mole. This finding suggests that ova from adolescent or older women may be more susceptible to abnormal fertilization that will result in a complete hydrated form mole. The risk of partial mole associated with the use of oral contraceptive history of irregular menstruation, but not within dietary factors. Pathology of and cytogenetic hydrated form karyotype either complete or partial based on the gross morphology and histopathology and karyotypes. The complete hydrated form will exhibit characteristic swelling, the trophoblastic hyperplasia. Usually the karyotype is a complete mole, that will be absent one empty ovum. Empty ovum is there, so it will be 46XY karyotype, 90% cases, and 10% have a 46XY karyotypes. The molar chromosome usually are entirely paternally origin, the mitochondrial DNA of maternal origin. The complete mole usually arises from the ovum fertilized by haploid sperm, which duplicate its own, and the ovum nucleus may be absent or it is inactivated. You can see the image. This is the empty ovum. This is 23x. It can be till 23x the fertilization, endoduplication occur to homozygous 46XX. Then empty ovum is there. 23x, another sperm 23x, equal to 46x XY. This should be x heterozygous. Empty above 46x heterozygous. This is 46y is non-viable gametes. Okay, YY is not able to survive, non-viable gamete. Okay, remember this. Then partial mole. This characterizes the following pathological feature. First is the chorionic villi size with focal height difference swelling, cavitation, and marked trophoblastic hyperplasia. Marked villus scalloping is there. This is the differentiating point. Villus scalloping is the from the partial prominent stromal trophoblastic inclusion. Identifiable embryonic fetal tissue will be there. The partial mole always it will be a triploid characterized, that is 69 chromosome. The extra haploid set is chromosome is derived from the father. It is possible non-triploid partial mole don't exist. If it is non-triploid partial mole, when fetus is present in conjunction with the partial mole, it generally exhibits stigmata of triploid, including growth retardation, multiple congenital anomaly such as syndactyly and hydrocephaly. The advances in pathological diagnosis. When molar pregnancy is diagnosed early in the first time, the pathology is difficult to distinguish complete and partial mole or hydropia because the smaller villi, the less trophoblastic hyperplasia. In the early first trimester, because of small villi, less trophoblastic hyperplasia, more primitive villostroma, less global necrosis, all are like looking similar, like complete and partial as in the early trimester. It looks similar as such. Accurate diagnosis. For that accurate diagnosis, they develop by using flow cytometry to determine the ploidy status, if it is diploid versus triploid moles. Through assessment of biomarker also they use to paternally imprinted and maternally expressed gene product, that is if in complete mole biomarker that maternally expressed gene is absent, so P57. We didn't have because the complete mole generally have no maternal chromosome, so paternally imprinted gene product normally expressed only by maternal chromosome, so it should be absent. In complete mole, the nuclei of the villostroma cytotrophic cell don't express P57. Whereas all other gestation will be partial mole characterized by nuclear immunostaining. This cells complete mole is diploid, negative for P57, while hydropic abortion is diploid, sometimes triploid, positive for P57. And the partial mole is triploid, positive for P57. This is the advance in pathological for diagnosis. Familial recurrent molar pregnancy. Those family evaluation that due to they suggest that there will be a dysregulation of normal paternal imprinting of gene with loss of maternally transcribed gene likely to contribute to the pathogenesis of molar pregnancy. Familial recurrent hydrated form mode is rare occurrence. Recurrent hydrated biparental origin rather than a more usual androgenic origin. Genetic mapping show that in most of the family the gene responsible is NLRP7, that is executed on the chromosome 19. Mutation in the gene resulting in dysregulation of imprinting in the female gene line abnormal development of embryonic and extra embryonic. Disparity, the partial mole showing marked disparity in the villus size, trophoblastic inclusion in the center, mild trophoblastic hyperplasia. This is the partial mole genome 23x, 23x. This can be 69 triple x, 23x, 23y, 23, 69x double y, and 23 is all x, 123x, 23y, 69 xxy. Three possibility, and if it is only y, then it will be non-viable gamete. Remember. Then clinical feature. Patient with complete molar pregnancy are diagnosed increasing earlier in pregnancy, treated before they develop classical signs and symptoms. This is the result many changes in clinical practice, such as frequent use of HCG measurement previous in early pregnancy, when vaginal staining determining gestation date is the following description. They complete what are the clinical features. First one is vaginal bleeding is the most common symptom. causing patient to seek treatment for complete molar pregnancy. 46% molar tissue separate. How the mechanism? The molar tissue may separate from the decidua that will disrupt the maternal vessels. Large volume of retained blood may distend the endometrial cavity. Because of vaginal bleeding considerable prolonged in the first half of the patient, they may develop anemia. So you have to preoperatively you have to correct the anemia only in 5% patient. Another thing is there will be excessive uterine size enlargement related to the corresponding gestational age, one of the classical signs of the complete mole. Although it was present only about half of the patients. Excessive uterine size only 28%. Endometrial cavity is expanded by chorionic tissue retained product. Excessive uterine size generally associated with markedly elevated beta CC, and because of uterine allergy, it is trophoblastic overgrowth. This is the fetal syndactyly partial mole because of triploidy. Bottom micrograph showing fetal hand demonstrating syndactyly. Here the syndactyly, you can see the fusion syndactyly, triploid karyotypes, and the coronary tissue were partial mole. Okay. What are the other clinical features? The patient may be susceptible to develop preeclampsia, hyperthyroidism, hyperemesis gravidarum. Okay, preeclampsia observed in 27% of complete hydrated mode. Although preeclampsia is associated with hypertension, proteinuria, hyperreflexia, eclamptic can rarely occur. Preeclampsia develops almost excluding in patient with excessive uterine size and marked elevated HCG. Hydrated force should consider those who have developed early onset preeclampsia. You should suspect there may be some hydrated. You can suspect because of complete partial hydrated mode. Then another thing is hyperemesis gravidarum. Hyperemesis recurring antiemetic and IV replacement therapy. Mostly 25% patient, particularly with the same uterine size enlargement and marked HCG, can manage with electrolyte imbalance and with fluid. Hyperthyroidism observed 7% patient. This because of complete molar gestation. They may have present the tachycardia, warm skin tremor, diagnosis is confirmed the detection of the elevated serum level of free T4 and T3 level. Complete mole is clinical evidence of hypothyroidism with complete mole is rare. Anesthesia has to be informed regarding the hypothyroidism may precipitate the thyroid storm during the procedure. Thus, if hypothyroidism is suspected before the induction anesthesia, alpha adrenergic blocking agent should be administered. Thyroid storm may be manifested by hyperthermia, delirium, convulsion, tachycardia, high count, heart failure, cardiovascular collapse. So you have to admit a beta adrenergic blocking agent to prevent the rapid reverse many of the metabolic and cardiovascular event. Hyperthyroidism develop exclusively in patients with very high HCG level. Trophoblastic embolization. Respiratory distress rarely occur in patient. Respiratory distress rarely occur in patient with complete mole. Patient may have chest pain, dyspnea, tachypnea, tachycardia, may experience severe respiratory distress during aftermolar evaluation. So always do an auscultation of the chest wall, reveal diffuse rails, chest radiography, evaluate may show bilateral pulmonary infiltrate. Respiratory distress usually resolve within 72 hours with cardiopulmonary support. In some sort, patient may require mechanical ventilation, respiratory insufficiency, result trophoblastic embolization. So cardiopulmonary complication of thyroid storm, preeclampsia, massive fluid replacement. Because of these things, there will be this. Then another thing is thecal uterine cyst. There will be prominent thecal size is 6 cm diameters, develop about one half of the patient with complete mole. Thecal uterine ovarian cyst result from a high serum HCG level which causes ovarian hyperstimulation. Because of the uterus may excessively enlarged, thecal uterine cyst can be difficult to palpate during physical examination. However, ultrasonography can accurately document their presence. After molar evacuation, the thecal uterine cyst normally regress spontaneously 2 to 4 months after evacuation. No need to do any intervention during the surgery. Prominent thecal uterine cysts can cause symptoms like marked pelvic pressure. They can decompress by laparoscopically. If you're doing, then you can decompress, or ultrasonography direct aspiration you can do if they are patients with symptoms like pressure and pain. If the acute pelvic pain develops, laparoscopy should be performed to assess the possible cystic torsion and rupture. Okay. Partial moles, what are the complications? Patient with partial mole doesn't have the dramatic clinical feature characteristic like to the complete mole. So this patient has the sign symptom of incomplete or missed aversion. Remember the difference from the complete mole. All these things like preeclampsia, hyperthyroidism, thecalutein cyst, and respiratory distress problem. All these things are more common and in complete mole. And in incomplete mode there will be the presentation more likely to be like incomplete abortion and missed abortion, and a partial mode is diagnosed histologically by apparatus. No patient decalated ovarian cyst, hyperemesis or hypothyroidism. Okay. Then natural history of the disease. Usually there will be a potential for local invasion, the complete mole dissemination. After evacuation, there will be chances of 15% patient local uterine invasion and 4% will develop metastasis choriocarcinoma. Then how we will suspect the signs that will mark the proliferation at the time of self-treatment. If beta SSC is more than 1 lakh, excessive uterine enlargement, theca lutein is 6 cm diameter or larger. All these things are important. One is more than 1 lakh, more than 1 lakh. Okay, 6 cm more enlargement. In this review, patient any one of the sign, if she develop any one of the sign like the beta SCC more than 1 lakh, uterine size more and thick uterine size more than 6 cm, then these are all are high risk for developing post-molar tumor. Like after molar local uterine invasion 30%. Older patient usually at risk for developing post-molar gestational trophoblastic neoplasia. Then in partial high-tetrated mole, how the disease progress. Persistent tumor usually they are non-metastatic. Approximately 1 to 4% patient with partial mole chemotherapy is required to remission. Patient who develop persistent disease, no distinguished clinical and pathological characteristic. How will diagnose partial and complete mole? Ultrasound is a reliable and sensitive technique for the diagnosis of complete molar pregnancy because the chorionic will exhibit diffuse. Here though in complete mole there will be a diffuse hydropic swelling. Complete mole produces a characteristic vesicular ultrasonographic pattern as the early as the trimester. Ultrasonography may contribute to the diagnosis of partial molar pregnancy by demonstrating focal cystic spaces in the placental tissue and increase in the transverse diameter of the gestational tract. With the criteria, positive predictability is 90%. Treatment of the molar pregnancy is diagnosed. Patients should be evaluated in the presence of associated medical complications like preeclampsia, hypothyroidism, electrolyte imbalance, hyperemesis, anemia. After patient stabilization, plan for evacuation. The suction curette is the preferred method of evacuation regardless of uterine size and patient who desire for future fertility. Yeah, what will do the steps of the procedures: oxytocin infusion, the procedure before the induction anesthesia, cervical dilatation, suction curettes, or curettes. Cervix is being dilated, uterine bleeding often increases. Return blood and the abdominal cavity may expel during the cervical dilatation. Active uterine bleeding should not deter the prompt completion of cervical dilation. Suction within a few minutes of commencing suction curettes, the uterine size may decrease dramatically and the bleeding will be well controlled. The use of 12 mm cannula is strongly recommended to facilitate the evacuation. If the uterus size is larger than 14 weeks, one hand should be placed at the top of the fundus and the uterus should be massaged to stimulate the contraction, reduce the risk of perforation. Sarcoidosis evacuation to be complete, gentle sarcoidosis to remove any residual molar tissue. Then hysterectomy, because of the trophoblast cell express the RHD factor. So patient who are Rh negative mother, you should give immunoglobulin. Hysterectomy, if the patient desires surgical sterilization, a hysterectomy may be performed with mole in situ. The ovaries may be preserved at the time of surgery even in the presence of prominent theca lutein cyst. Large ovarian cysts, they can be decompressed by aspiration if more than 6 cm with symptoms of torsion, rupture, acute pelvic pain. Hysterectomy, don't think that after doing hysterectomy everything is lost, but everything is has been clear, but nothing like that. Hysterectomy doesn't prevent the metastasis, but patient has to still recover the fall of the beta hCG level. Prophylactic role of prophylactic chemotherapy at the removal level is controversial, but some are telling it can be useful if it is like high risk. The prophylaxis may be particularly useful in managing high risk complete molar pregnancy, especially with hCG measurement. Follow-up are unavailable or reliable. If they are on, if the follow-up is unavailable, they are not doing proper follow-up. You suspect unreliable, then you can do is prophylactically chemotherapy. Follow-up, how will do follow-up? After molar evacuation, patients should be monitored with the weekly beta hCG determinant alpha subunit until beta 7 level for 3 consecutive negative value, followed by monthly for until the level normal for 6 consecutive months. Weekly for 3 consecutive negative, then monthly for 6. The average time to achieve the first normal hCG level after evacuation is about 9 weeks. After achieving non-detectable serum, the risk of developing hCG approximately 0. Contraception, encouraged to use effective contraception during the entire interval of hCG follow-up period. So potential risk is that there will be uterine perforation, bleeding and infection. Intrauterine device should not be used during the hCG follow-up. Once the uterine normal, you can use either patient not desired for surgical sterilization, either oral contraceptive or barrier method should be used. Increase incident post-molar persistent trophoblastic tumor among patients who are using oral, but now the recent data suggesting there is no oral contraceptive doesn't increase the risk of post-molar trophoblastic disease. Does not increase post-molar trophoblastic. OCP will not increase. It appears that oral contraception may be used safely after molar evacuation to the entire interval safe. Then GTN, the non-metastatic disease and metastatic disease. Non-metastatic disease about to develop 15% of complete mole after post-molar evacuation. 15% of patient develop infrequently after other gestation. This patient usually with the following symptoms: 50% irregular vaginal bleeding, thecal uterine cyst, beta hCG persistently elevated, uterine subinvolution, asymmetrically enlargement. The trophoblastic tumor may perforate the myometrium, causing intraperitoneal bleeding and eroding into the uterine vessel, causing vaginal hemorrhage. Bulky uterine tumor may involve the uterine wall, serve as a nidus for infection. Patient may be present with sepsis, purulent discharge, vaginal discharge, acute pelvic pain. After molar evacuation, persistent GTN may exhibit the histological feature either hydatid or choriocarcinoma. But after non-molar pregnancy, okay, if a molar evacuation is done, then it can be a molar recurrent mole or choriocarcinoma. But if it is a non-molar evacuation, non-molar pregnancy term, then mostly histologically it is developed into choriocarcinoma. Usual categorization depend on the site of anaplastic synthesis trophoblasts and without chorionebulae. Placental site trophoblastic tumor. These tumors are placental site trophoblastic tumor and epithelial trophoblastic tumor ongoing, but important variant is that predominantly intermediate trophoblast. Their origin intermediate trophoblast. ITB. Related to their mass, this tumor produces a small amount of beta hCGs and human HPL. They tend to remain found by the uterus. Usually they confine to the uterus. Metastasis later in their course. In contrast to other trophoblasts, they are relatively insensitive to chemotherapy. So mostly we are doing in hysterectomy for this. Metastatic disease. Metastatic GTN occur only 4% patient after evacuation and complete mole, but it is seen more often GTN after non-molar pregnancy. GTN usually metastasizes as chorioascin because it tendency of early vascular invasion with widespread dissemination. The trophoblastic tumor often profuse facile basal, so it will frequently hemorrhagic. Symptom of metastasis may result from spontaneous bleeding and metastatic depending on the site of the metastatic foci. The most common site is the lungs, 80%. Then lungs is the 80%, then vagina is 30%, pelvis is 20%, liver is 10%, brain is 10%. Pulmonary, at the time of diagnosis, the lung involvement by chest, you can see by the chest radiography of 80% of the patient with metastatic GTN. Patient with pulmonary metastasis may have a chest pain, cough, hemoptysis, dyspnea, or an asymptomatic lesion visible by chest radiography. Respiratory symptom may acute or chronic, persist over many months. Four principal of pulmonary patterns. One is alveolar snowstorm pattern, discrete opacity, rounded density, pleural effusions. Embolic pattern may lead to pulmonary arterial occlusion that lead to pulmonary arterial hypertension. Because of respiratory symptom or radiography finding may be dramatic, the patient may like to have a primary pulmonary disease. Some patients with extensive pulmonary involvement have minimal. So, if any gynecological symptom, because the productive organ may be free of trophoblastic tumor. The diagnosis of GTN may be confirmed only after the thoracoscopy is performed, particularly with patient with non-premolar antecedent pregnancy. Pulmonary hypertension may develop in patients with GTN due to pulmonary arterial occlusion by trophoblastic emboli. The development of early respiratory failure due to embolization, recurring intubation, as to the poor clinical outcome. Vaginal, there will be bleeding. 30% of patients with metastatic disease level highly vascular may lead to vigorous bleed during the biopsy. Most location is pernicial and suburethral location. Pernicial and suburethral may produce irregular vaginal bleeding and purulent discharge if it is infected. And hepatic metastasis, there will be a disseminated roughly 10% chances. Hepatic metastasis protracted delayed in diagnosis because of extensive epigastric and right upper carotid pain may be due to capsular stretching by the metastatic tumor. Hepatic, there will be hemorrhagic causing hepatic rupture, exsanguinous intraperitoneal bleeding. Central nervous system, metastatic trophoblastic is the 10% of the patients. Cerebral lesion, mainly Alzheimer's disease. Virtually all patients with brain metastasis concurrent, already they concurrent with the vaginal pulmonary involvement of both. There will be, because of cerebral lesion, there will be frequent hemorrhage, spontaneous patient develop acute focal neurological deficit. Staging and prognostic score. Anatomic staging for GTN adapted by the FIGO International Guideline. That score staging. Patient stage 1 is patient who have persistently elevated ECG, tumor confined to the uterus, corpus. Stage 2, patient have metastasis to the genital tract, adnexa, broad ligament, ovary, vagina. Stage 3, patient have pulmonary metastasis with or without involvement the uterine, vaginal, and adnexal involvement, pelvic involvement. Diagnosis based on rising trend of HCG level in the presence of pulmonary lesion, viewed by plain chest radiography, not chest CT. Patient have an advanced disease involve the brain, liver, and kidneys, GI tract. These patients are in the high risk pregnancy, high risk category because they are most likely resistant to chemotherapy. Choriocarcinoma is usually present. The disease commonly follow non-molar pregnancy. This is staging, FIGO staging. That is, stage 1 is confined to the uterus. Stage 2, GTN extending outside the uterus but limited to the genital structures like adnexa, vagina, broad ligament, extending the lungs with or without involved the genital structure involvement. Other metastasis like liver, brain, kidney, GI tract. Prognosis scoring system. In addition to anatomic staging, it will consider other variable to predict the likelihood of the drug resistance to assist the selecting appropriate chemotherapy. Prognosis score system is approved by the WHO, predict the potential resistant chemotherapy. When the prognosis score is higher than 6, patient is categorized as high risk, requiring multimodal therapy like combination chemotherapy. Intensive combination chemotherapy may include surgery and radiation to achieve remission. Patients with stage 1 disease usually have low risk score. Those with stage 4 is high risk score. The distance between the low and high risk is patient between the stage 2 and stage 3 disease. So scoring system for WHO, the 1, 2, 3, 4, 5, 6, 7, 8, 9 point. First is age. If it is 0, 1, 2, 0, 1, 2, 4, it is less than 39, more than 39 years, antecedent pregnancy. If it is a high rated mole, that is score is 0, it is abortion, it is 1, it is term pregnancy, score is 2. In interval between the end of the antecedent pregnancy, start of chemotherapy, months, if it is less than 4 months, It is 0. 4 to 6 months is 1. 7 to 12 months is 2. More than 12 months is 4. The human chorionic gonadotropin level at the time of diagnosis of the GTN, if less than 1000, 1000 to 10,000, 10,000 to 1 lakh, more than 1 lakh, 0, 1 to blood group. AB blood group, if O or A blood group, its score is 1. B or AB blood group, O or A is 1, AB or AB is 2. Largest tumor including uterine size, if less than 3 cm size, is 0. 3 to 5 cm 1, more than 5 cm 2. Site of metastasis, if it is spleen and kidney, it is 1. GIT is 2. Brain and liver is 4. Number of metastasis 1 to 3, number 4 is 1. 4 to 8 is 2. More than 8 number is 4. Prior chemotherapy, 1 drug chemotherapy, multi drugs, more than 2 drugs, 1 drug is 2, more than 2 drug is 4. Already there will be resistance, so it will like that. Total score, if less than 7 it is low risk, more than 7 is high risk. The diagnosis, optimal management procedure required through assessment. All patient persistent GTN under careful pre-treatment evaluation, include the complete history and physical examination, measurement of serum acid level, hepatic thyroid renal function test, determine the baseline peripheral blood platelet count, because you are giving the chemotherapy isn't like methotrexate under actinomycin, doxorubicin. The metastatic workup like chest radiograph, CT scan, see below size of metastasis, ultrasonic abdomen, pelvis, look at the CT angio, MRI, brain is indicated. When the pelvic examination chest radiograph negative, then metastatic involvement of the side is uncommon. Liver ultrasonography, CT MRI disclose the most hepatic manifestation with abnormal liver function test. CT MRI scan of the head facility, the early diagnosis of asymptomatic cerebral lesion. Chest CT can made it with micrometastasis not visible in chest radiography. Chest CT will demonstrate pulmonary micrometastasis about 40% of patient with presence of non-metastatic disease. Presence of pulmonary micrometastasis not to be shown to substantially change the clinical outcome. In patients with choriocarcinoma, metastatic disease, HCG level may be measured in the CSF to exclude the cerebral element. If result CT or MRI is abnormal, the ratio of CSF plasma, beta HCG plasma to CSF is 60. If more than 60, if it is lower than 60, the presence of cerebral metastasis is suspected. A high signal plasma is not misleading. Preliminary ultrasound will appear to be useful in the detailed extensive trophoblastic uterine environment, may identify the site of resistant uterine tumor. Management of GTN, if it is low risk disease and high risk disease, the protocol method table already I have told. The low risk or high risk, if it is less than 7, if it is more than 7, stage 1 is low risk, stage 4 is already high risk, 2 and 3 is based on the scoring system, 2 and 3 based on the if it less than 7 low and more than 7 is high risk. Low risk GTN include the patient with both material stage 1 and stage 2 whose prognosis less than 7. Patient with stage 1 disease is based on primarily then treatment based on the return fertility. If they return to fertility, then you will give chemotherapy. They doesn't return, hysterectomy plus chemotherapy. If the patient doesn't wish to preserve fertility, hysterectomy with adjuvant single agent chemotherapy perform as a primary treatment to reduce the what are the best adjuvant therapy. Why you are giving adjuvant therapy? Because during the surgery, reduce the likelihood of disseminating viable tumor at the surgery, maintain the cytotoxic level of chemotherapy in the bloodstream. In case the some viable tumor cell are disseminated surgery, that will be prevented by the level of the cytotoxic chemotherapy in the bloodstream. Third one is the treat any occult metastasis that present at the time of surgery. To treat occult metastasis के लिए, one is to reduce the likelihood of disseminating viable tumor, and if at all it will disseminated, then you have the cytotoxic level of chemotherapy level that will maintain, that will do the rest viable tumor occult metastasis. Chemotherapy can be administered safely at the time of hysterectomy without any risk of bleeding, sepsis. Hysterectomy is before patient is stage because this placental side trophoblastic tumor and epithelial tumor, they are not they are relatively resistant to chemotherapy, so we'll directly go for stage 1. In stage 1 we'll go for hysterectomy, which is going to be non-metastatic, the most current patient metastatic still achieve remission, but that you are less respond to chemotherapy. Stage 1 single agent chemotherapy or hysterectomy with adjuvant single agent if they want fertility preserving therapy. If they don't want fertility preserving, single hysterectomy with adjunctive chemotherapy. Then resistant treatment, combination chemotherapy, hysterectomy with adjunctive chemotherapy, local resection and pelvic infusion. Stage 2-3 based on the low risk and high risk, it will if it is low risk, if initial treatment will be in single agent, resistant will be combination. If it is high risk, initial treatment is combination, resistant will be second line combination. Stage 4, like it will be already high risk, so initial combination chemotherapy. If it is brain metastasis, depending on the side of metastasis, we will treat the brain, whole brain radiation, craniotomy to manage the residual tumor, manage the bleeding complication, liver resection of the or embolization to manage the complication. Resistant हो गया तो second line combination chemotherapy or hepatic arterial infusion. Chemotherapy alone, single agent and combination chemotherapy. Seeing the preferred treatment, the stage 1 under low risk disease written fertility. Women patient disease resistant to single agent chemotherapy, you can desire to preserve fertility, you can combination monotherapy can be administered. For the local resection is planned. Patient resistant to single agent combination therapy, say want to retain fertility, you can go for a local uterine resection. When local resection is planned, a preoperative ultrasonography, MRI, PET scan should be performed to help define the site of resistant tumor. Low risk GTN stage 2-3, vaginal pelvic metastasis, low risk treated with primary single agent chemotherapy. As high 40% rate controlled high risk disease, they will don't resolve achieve remission. So require treatment with the primary intensive combination chemotherapy. Vaginal metastasis may be bleed profusely as they are highly vascular friable. The bleeding is substantial. You can control by packing by vagina or by wide local excision. Infrequently, you can go for arteriogapping embolization of the hypogastric artery. Remember, this artery is hypogastric artery. Pulmonary metastasis, the remaining already it is high risk, so you will go for combination chemotherapy. You are disease resistant chemotherapy. Thoracotomy has limited but important role in the pulmonary metastasis. Patient have persistent viable pulmonary following intensive chemotherapy, main leading excision surgery. Although metastatic workup should be performed before surgery. The fibrotic pulmonary nodule may persist indefinitely on chest radiography even after complete gonadotropin remission is attained. Patient is undergoing thoracotomy resistant disease, chemotherapy should be administered post-operatively to the potential local site of metastasis. Remember, even after beta-SCC normal, pulmonary nodule persist indefinitely. Hysterectomy is the may require patient with metastatic disease to control the uterine hemorrhage or sepsis. Patient with extensive uterine tumor, hysterectomy may be substituted with the trophoblastic burden, limit the multiple course of chemotherapy. All patients GTN undergo follow-up with weekly measurement of beta HCG till normal 3 consecutive negative value, monthly measurement for 12 months. Remember, for molar pregnancy follow-up, it is for molar pregnancy post follow-up for 6 months. For GTN for 12 months. Okay. Effective contraception during the interval follow-up. High risk cases, all patients with stage 2, stage 4 should be treated with primary intensive combination chemotherapy, selective radiation therapy, and surgery. Improvements available from the multimodal therapy, primary combinations and the radiation surgical treatment. Patient stage 4 have the greatest risk of developing rapidly progressive unresponsive tumor. Despite multiple, they should be referred to Central Special Trophoblastic Disease Management. Hepatic metastasis management resistant hepatitis is particularly difficult. If a patient becomes resistant to systemic chemotherapy, hepatic arterial infusion chemotherapy may induce complete remissions. Hepatic resection may require to control blockade bleeding, exercise focus resistant tumor. Arterial embolization may reduce the need of surgical intervention. Cerebral metastasis, whole brain radiation, 3000 centigrade, 10 fractions, stereotactic radiation surgery in conjunction with combination of chemotherapy. Because of irradiation, there will be hemostatic and tumoricidal. The risk of spontaneous cerebral hemorrhage may be lessened by a concurrent use of craniotomy, combination chemotherapy and brain radiation. Cranial metastasis treated with intensive IV methotrexate intrathecal. Craniotomy may be provide acute decompression to control the bleeding. It should be performed to manage life-threatening complications so that patient ultimately will cure with chemotherapy. GTN patient, the single agent chemotherapy like actin either methotrexate comparable, excellent remission both non-metastatic and low risk GTN. 260 patient. I will give methotrexate. Five days regimen. is the GTN हो गया. How will the manage the follow patient? How will follow? GTN हुआ is suspecting molar pregnancy or chorea carcinoma. If it is molar pregnancy, evacuation weekly with anesthesia level. If it is decreased level, then careful follow on contraception till the follow period 2 weeks. Is increasing a plateau or increase metastatic workup has to be done. In metastatic, whether the disease is limited to uterine disease, it is pelvic disease, it is long metastasis, it is distant metastasis. It is stage 1, then you single drug chemotherapy. Stage 1 single drug chemotherapy, pelvic metastasis stage 2, and long metastasis stage 3. 2 and 3 is between the, you have to is stratification stage 2 and 3. It is low risk or high risk based on the less than 7 or more than 7. Then stage 4 distant metastasis, combination chemotherapy, surgery plus or minus radiotherapy. If it is low risk, then you go for a single. If it is high risk, you go for combination chemotherapy per surgery. Combination chemotherapy, single drug, then you follow. If it is resistant, then single combination chemo surgery plus or minus radio. Management gestational trophoblastic neoplasia. Technique single agent therapy. Single agent therapy, 3 consequences include the risk of relapse, resistance to chemotherapy, diagnosis SSG 10% 2 weeks level treatment. Combination triple therapy is IMACO regimen. Okay. IMACO will tolerate treatment because toxicity. A patient resistant IMACO substitution etoposide cisplatin. IMA-IP regimen reduce emission alone with surgery. Management of refractory, if what continue to identify the new agent regimen effective group resistant to all standard therapy. Combination of cisplatin, vinblastine, PVB regimen. Little patient the drug, although hypospadipathogenic cell can be used. Fluorouracil. The patient requiring combination chemotherapy must be treated intensity or termination. Combination should be given upon toxicity until the patient achieves 3 consecutive normal level. After the normalization, remember after you chemotherapy continue till beta HCG 3 value normal, then again 3 additional chemotherapy to reduce relapse. Pregnancy after uncomplicated high-treated mole, patient can anticipate normal reproduction in the future. Patient with complete mole and partial should be that there are generally no increased risk of complication later. When patient had molar pregnancy at the partial complete, she should inform that increased risk of having molar gestation. Subsequent complication after 1 molar, the risk of having molar disease is 7 to 5%. For any subsequent pregnancy, should be undertaking following approach. Perform pelvic ultrasonography examination of confirm normal gestational development. HCG measurement after 6 weeks after completion of the 6 weeks after completion of the pregnancy. Pregnancy after GTN, patient GTN were treated successfully with chemotherapy can expect normal reproduction in the future. First and second trimester spontaneous abortion can occur. Major minor congenital malformation in 12 we can not increase, although chemotherapy doesn't have a teratogenic mutagenic fashion.